Hello, everybody, and welcome to today's Daily Science Recap from International Stroke Conference 2021. My name is Mitch Elkind, and I'm the president of the American Heart Association and American Stroke Association, and I have the pleasure of being joined today by Dr. Louise McCullough, who's the chair of the planning committee for the International Stroke Conference, Dr. Tudor Jovin, who's the vice chair of the International Stroke Conference Committee, and Dr. Peter Panagos, who's the chair of the Stroke Council of the American Stroke Association. And I think it's been just a tremendous day, in fact, a tremendous week of presentations all around. Just as kind of a general sense, I'll say to you guys, I feel like we're really closing in on stroke treatment from both ends. You know, earlier this week, we heard from Dr. Grotta about how using a mobile stroke unit can increase the proportion of patients who get treated within that first golden hour after stroke onset from 3% to 30% and improve clinical outcomes by doing that. And then today, Tudor, you presented the results of the Aurora collaboration, which showed that endovascular therapy started beyond 6 hours is actually very effective. In fact, it's no less effective than treatment started even earlier. And I know you found some other interesting findings about how treatment started later seem to have some even greater benefits in some ways. Can you tell us a little bit more about that?
Yeah, that's something that was indeed surprising to us. But in fact, if you think about it, the explanation is not unreasonable. We found that patients who were randomized in the later time epoch, 12 to 24 hours, derived stronger benefit. That's not to say that they did better, because in fact they didn't do better. They did numerically slightly worse, okay? But the treatment effect, the difference between intervention and control was more pronounced in the later time epoch. And of course, there's the explanations for that are a bit speculative because we didn't have the data to look for that specifically, but we think that this is because patients who present later in time are less likely to recanalize spontaneously, right? And that's something that we know even from the earlier time window. So the earlier you are in time and have an occlusion, the less likely it is that you're going to recanalize on your own. And these are the patients in general who are going to do well, the ones who recanalize on your own. Also, in the and that was not shown in the early time window patients. There was about 20% of patients who were treated with intravenous TPA. These were patients who were transferred from an outside hospital, showed up at the thrombectomy center beyond 6 hours. Whereas in the later time epoch, there was virtually nobody who was treated with IV TPA. So in the control group, the patients who were treated with IV TPA also might have contributed to better outcomes in that time epoch. So anyway, the other very encouraging finding was that it's not only dawn and diffuse where there's a direction of benefit. The other trials also trended in the direction of benefit as well. So that's very encouraging because that's a heterogeneous patient population with respect to selection, and also geographically. There were patients from Brazil, more patients from Europe, and so on and so forth. So I think that basically the knowledge that sort of begins to crystallize is that in the early time window, time is extremely important, and we select patients based on time in the sense that probably physiological data is not that important. The number one priority is get the patient reperfused, and then as we go further along in time, time becomes less of an issue in terms of selecting patients. But also it underscores the concept that once we deem a patient a candidate for reperfusion, time is of the essence. So it doesn't mean that we can afford delays at any period in time. delays to reperfusion once we deem that that patient is a candidate. But that determination should not necessarily be based on time, especially in the later time window.
That's great. And I just have to jump in and ask you a further question, Tudor. So we also heard from Jeff Saver about these new Tiger Triever devices that are radially adjustable and fully visible. It sounded very exciting. There were some neat results presented there. I don't know if you've used that device yourself or what your thoughts are. Does that change the field at all as well?
I have used the device. We were a participating site at University of Pittsburgh, where I practiced until 2 years ago. And it's another useful tool in the toolbox, really. So especially many of us are excited about the smaller vessels. Now we're going after more distal vessels, and I think that's where this also can bring something definitely novel in our armamentarium. And overall, the results are pretty impressive. So yet another good addition to the modalities that we already have. I do think, though, that in terms of refining our thrombectomy techniques, we're getting to diminishing returns. I think the big bang for the buck is in the systems of care still. That's where you make the big gains. But very encouraging and great results, and the Tiger Retriever investigators should be congratulated.
Terrific. So maybe, Peter, you can tell us what you enjoyed learning about today.
Yeah, thanks, Mitch. I really enjoyed all 3 days of the program, but for some reason today's content, even before the final closing session, I found really fascinating. I found myself jumping, or maybe at this age, crawling out of bed this morning, conflicted about what I was going to watch live and what I was going to have to go back and watch recorded. Fortunately, everything through this virtual format is accessible. So I was able to watch most of all the morning content before even the main closing session. It started out with a really fascinating talk on prevention of stroke and COVID-19 with great moderators, overview of COVID-19 treatments, long-term and kind of long-haul type of symptoms that involve the brain. And I thought it was really fascinating and really, understood that the story is really not written yet on what we're going to see in long-term COVID-19 infection in our patients. And then a fascinating debate on stroke in the young, which all caught our attention early in March and April when we saw the press reports of stroke associated with young, and a great discussion with Dr. Kamel and Zackerson about causation versus association when looking at science. It moved right into really the theme of this meeting, which is the age of thrombectomy, thrombolysis, does it still have a role in LVO? Great debate with Dr. Hill from Calgary and Dr. Kappelhoff from Amsterdam, talking about the use of thrombolysis in mechanical thrombectomy. And really, what I was really took away from that was the importance, I think, of the Mr. Clean No IV trial, and this, based upon the superiority design versus the non-inferior design of the other trials which we heard about, which are really important, but just the importance of that design, study design, and how and what we can take from that. And another important lesson for that whole session was that we continue to talk about bridging therapy, and it's not really buying time, but rather it's treating the stroke patient simultaneously with the entire cohesive goal of recanalization. So I think when you think about bridging therapy in those terms, it really makes a lot of sense. And next we move to something that I spent a lot of time on, is multimodal imaging, CT, CTA, multi-phase imaging, hub versus stroke model. And I think the discussion on how to use that technology, is it ready for prime time or is it still experimental, was a great debate. And then a talk about ICH treatment, and moderated by Dr. Steiner and Mayer, looking on ongoing clinical trials, review of hemostatic agents, blood pressure reduction, value and efficacy of ICH removal, timing versus volume. Really kind of a fascinating discussion, state of the science, in the era of Interact 3, Interact 4, big data and analytics. And then a great session on data, biggest data in stroke, which tied in really well with the closing main event talks on temporal trends and endovascular therapy by Dr. Sharif on behalf of Get With The Guidelines investigators, and Dr. Shaquille talked about the exciting COVID-19 registry that the AHA was very instrumental in designing. And I know you have some thoughts about those registry presentations.
Well, I'll say, Peter, that I can tell immediately that you're an emergency room doctor, because you managed to get in all those sessions this morning simultaneously somehow. I don't think any of us could have gotten as much out of it as you did, but that was a great summary. Yeah, I thought that the presentations from Dr. Sharif and Dr. Shaquille about the Get With The Guidelines programs were great and really illustrate some of the strengths of what the Heart Association is able to do. I think the first one about the increase in the use of endovascular therapy from Get With The Guidelines stroke was really neat. It showed that rates of endovascular therapy have been going up. They've been going up across all the different race ethnic groups. There's a narrowing of the disparities in the use of endovascular therapy, but we still see that we're not quite there yet, right? So that we see that in the Black population, there's still perhaps an underuse of endovascular therapy. But I think there's a big caveat there, because we don't really know enough about the individual characteristics perhaps of the patients in the studies. It's not clear to me whether there's a differential in terms of who might be eligible for endovascular therapy. We know there's greater rates of hypertension, for example, in the Black population, and so it may be that some of the strokes in that population are smaller vessel strokes, and that might in fact account for some of the differences in terms of the short-term outcomes that they presented as well. So those might be smaller strokes, less likely large vessel occlusion than in the other groups. So we need some more granular data there probably. I was also really excited to see the final presentation. I was a co-author on that one as well, in full disclosure, but that showed the rates of stroke in patients with COVID from the cardiovascular disease registry focused on COVID patients. And there what we see is that, fortunately, the rates of stroke in patients with COVID from the registry were quite low, on the order of 1%, about half of those being ischemic strokes. They were overrepresented in the Black population, but also we could see that patients who had COVID and stroke had a worse outcome than those who had COVID alone. Maybe not surprising, since we know stroke will increase adverse outcomes as well. So I think a lot more to learn from this registry about characteristics of stroke and outcomes in patients who have stroke with COVID. So overall, I think a really exciting day, a great week. Louise, I'd love to hear from your thoughts of the entire process. How was it being chair of the meeting this year, a different year?
It was a different year. It was challenging, but we got through it, and I really appreciate the AHA's help and Tudor's help, and especially all the help of the program committee. The program committee really starts working very early. In fact, we'll start it in about 3 weeks for next year. And hopefully it will be as well received as this year, because overall the feedback has been very good. I think there's a couple big picture things that I took out of this meeting. One is how glad I am to see the consistency in the data with IV TPA or going directly to endovascular. Multiple groups have shown this, and it really is important that we think about offering treatment and offering it quickly. As shown in that mobile stroke study, the earlier treatment, the better the patients do. And I think that also leads into the intracerebral hemorrhage session, because the MSU programs are now starting a program for ICH to get hemostatic therapy in very quickly. So maybe there's a glimmer of hope from what we've learned from ischemic stroke for really getting those intracerebral hemorrhages, which now have so few options for treatment. Hopefully that will prevent further hematoma growth and reduce disability, and maybe we'll see that probably not next year, but maybe 2023. I also was really interested in a lot of feedback that we're getting through the press about TNK and Steve Warwick's experience that he presented in Austin, Texas, about switching systems from using TPA to TNK. Also a fantastic debate, as Peter mentioned today, from Calgary, and I guess it was very entertaining, so you guys should watch it, because he is now being called the man who we cannot use his name. A Harry Potter reference, very entertaining, funny, great experts. The work on COVID, Dr. Buckwalter gave a great scientific program. Hopefully next year we're going to have learned a lot more about COVID, and we'll see some basic science and translational science on that topic. So really reflecting back on this meeting, yeah, it was a different meeting. It was very different. And we think back to where we were a little over a year ago in LA, in person, with no idea of the impending catastrophic pandemic, which we've all been touched by. It was just a few short weeks away. So I think it's been a challenging year for all of us. Really glad that people were so engaged with this virtual format. I hope to see everybody in person with their Mardi Gras beads and their masks, because we'll probably still be wearing them next year, November. Maybe not, we'll see with the vaccines, back in New Orleans, live 2022.